Okay, well, this is a very big treat for me. And Dr., of course, you've heard him before, Dr. William Leone. He is the Leone Center at Orthopedic Care. He is the one that helped my husband so much with gorgeous hips. He's had 4 hip replacements, and Bill is just fantastic. And of course, Dr. Leone does hips and knees, and we're going to talk a lot about, why don't we just give a little rundown for people who don't remember you, who you really are. Who are you? Who is this gorgeous man who makes people feel so good?
Well, I have a big smile as you say that, so thank you. And you're an old friend, and it's a privilege to be back on your show.
Same for me to have you here.
I'm an orthopedic surgeon who's really been in one place at Holy Cross Hospital in Fort Lauderdale. August 25th will be 25 years, which is just amazing. And my practice is limited only to really reconstructing and helping people with complex hip and knee problems. And so I've been kind of the go-to guy when they need a replacement, or they have a complex fracture, or they haven't done well, and we got to figure out what we need to do to get them going. So that's really what I am.
But you're an inventor. You forgot that. It's very important.
Thank you. When you do an awful lot of one thing, you have the advantage of seeing nuances and being there so much, you begin to see ways that you can make it easier. You see where the stumbling blocks are. So what you're referring to is the pelvic alignment level, which is a very simple, intuitive a device that really helps me get the components right when replacing a hip. There are certain assumptions that are made when you place the components, and if you don't place the cup right and you don't get the stem to the right length and the right twist, then the leg feels long, or it dislocates, or it doesn't wear like the manufacturers and the engineers and everyone had hoped it would, and they wear out quicker, or they fail. So by recognizing what assumptions we have to make when we place the components and being able to much more accurately get our hands around those assumptions and eliminate them and quantitate them and remeasure them and come back and recheck them, it makes it so much more predictable. And that's really been my key to being able to do really so much and be able to do it over and over.
Right, you've always done the cutting edge. You're right. It's not, there are a lot of orthopedic surgeons, and they follow the pattern and they do it, but you have always been extraordinary. But I want to move way back. I want to ask you a few questions about people and their knees and hips. Is it? Let's say someone isn't an athlete and they just live a good life and they watch their weight. Will they always have to come and see you? Or
definitely not. I think a fallacy is that just because someone is very active and they are very athletic, they're going to wear out their joints. The reality is the vast majority of people who certainly wear out their hips, but even much on the knee side, is due to some genetic variables, either genetic predisposition towards a type of arthritis, or because of some biomechanical abnormalities. Particularly with the hip, 90% of the hip replacements are done for people who have a diagnosis of osteoarthritis. 10% others failed fracture, AVN, others. Of those 90% that are going to have a hip replacement for osteoarthritis, 90% of those develop their osteoarthritis due to something else. It's a secondary osteoarthritis, and almost always it's due to some subtle biomechanical abnormality. They have overcoverage of their acetabulum, or they have undercoverage, a degree of dysplasia, or so there's usually some genetic predisposition.
I'm glad you mentioned that, because I look back, my mother lived to be 94, and only when she was 90 and she fell did she have to have a hip replacement.
Right.
But so that's a good genetic. And my father was 88 and he never had anything. So does that, when you think about it, so you're saying that unless I fall, and that's true, the falling is when, if you do have a little arthritis, then that.
Well, what happens when we age is we lose some of our ability to know where we are in space. So there's loss of balance, there's loss of proprioception. It's more difficult to see, and you stumble and you fall. But typically it's not one fall, it's a number of falls, and ultimately you really hurt yourself. And then because of a process of bone loss. Even though the bone is very normal and it can heal normal, it changes shape. It gets wider, the medullary canals get bigger, there's more deposition of bone on the outside, there's resorption on the inside. It's a normal aging osteoporosis. Normal bone, not as dense. So then if you fall, you're more predisposed to fracture, certainly about the hip.
So I was thinking about you. So you have never had anything. Who would you go to if you had knee surgery needed or hip?
Well,
I don't know what you would do.
There's as important. All of us are the stars of our own novel, and we all think we're so wonderfully important. But the reality is we're so blessed to be in this world with not just this country, this whole world with so many great people. There's always good people. There's always people that look at it a little bit different and step back from it and come up with a new way of solving something. And that, if you have my personality, where I really appreciate those subtleties and those changes and the fact that someone could not do what everyone else is doing and kind of come up with not necessarily a better way. You have to prove that, but a different way. I love that.
Well, one thing that I have to share, of course, and I said this when we first started, that Dr. Leone has been Bill's savior in a way, because Bill's been an active person, and he had a very serious, though, bone loss. But I think it was caused, you had said that one of the hips he had, the hip replacements, the fiber of the part of it was falling down. You do remember what happened with him specifically,
I
remember?
know Bill so well.
Yeah, I know,
He's a brilliant ex-naval aviator and an author, but I remember I revised his hip, and I remember he had a significant amount of bone loss, and that typically what leads to the failure of all of these prosthetic joints, hips and knees, is that the substrate that the artificial parts are anchored into, the bone, which is the substrate, begins to disappear, begins to get eaten away, begins to eat itself away. And there's a very characteristic pattern that we see in the operating room and how it appears on radiographs, and that's called osteobone, osteolysis. Lysis is destruction of. So something is causing the destruction of the bone. And it's a process where mechanisms within the cells are being turned on. The osteoclast, the type of cells within our bone, normal cells that take away bone, not the osteoblasts that lay down bone, are eating away the bone. Something's turning them on, and what's turning them on is inflammation. And what's causing the inflammation, so what's causing the inflammation that's leading to the loss of bone is debris. And historically, the debris was plastic debris. Now, when we first started doing joints, we didn't really know what we were looking at. We could just see after 10 years the cement was fracturing and the components were loose, and we said, oh my goodness, we have cement disease. Well, it was the bone that supported the cement was disappearing, so of course the cement fractured. And then we created non-cemented components, and we saw a different pattern, but the exact same phenomena. Patches where it would still be bone ingrown or osseous integrated, but around it you'd see these areas of bone loss. And what we began to realize is the commonality is the production of debris, plastic debris, very tiny particles of plastic that turn on this process of bone loss. And what's changed in a wonderful, wonderful, wonderful way is the quality of the plastic. And across the board, all the major manufacturers are now doing the same thing in terms of improving the quality of the plastics by increasing the cross-links within the polyethylenes, and then figuring out how to tease out the oxygen-free radicals which are produced when they add energy to increase the cross-links. And they're all doing the same thing. They have different formulas. They all think they've got the holy grail, and they all say theirs are the best. But the reality is the quality of the plastics that we have now are truly a magnitude better than what we had, 10, 12 years ago.
But let's just go through, because I was the wife, and I understood what this was. So before Bill had the emergency, you said to Bill, I see some stuff, Bill, and I think we ought to plan to redo your hip. And then what you said was, it was pretty serious, but when we do this, you cannot put any weight on that hip for 30 days. Remember? I mean, this isn't because you had to get bone. You had to,
This is how many years ago? This is 10, 12 years ago.
Oh, yeah.
So there are a number of methods to revise a joint. And one of the methods, which is wonderfully biologic and truly rebuilds bone, is a method called impaction grafting. And that was a method that I used with Bill. And that's when you take bone from someone who's died from a cadaver bone, allograft bone from an American bone bank, and it's in a very special form. And basically you contain the bone within the shell. You may have to recreate the outside of the shell, and you pack it in very tightly, and then you cement in very specialized components, which then load the cement, and we keep weight off it for a period of time, and then truly it reconstitutes the skeleton. It's remarkable. Now, it's very time dependent, and it's resource dependent, and what's happened since then is prostheses have given us much more latitude, and we're much more effective now with metals that can do much of that. But his was done beautifully. That's why
it took
years later,
it took an
he's
artist
still
like you.
perfect.
Oh, I know. No, you took. This is a big deal. I don't know how many hours did it take. I mean, how many hours does it take you when you're in the operating room to do something that big?
People always ask me, how long does it take? And one of my truly, I think the only real gift I have is that I'm so focused in my own world that I can compartmentalize it. I'm completely doing what I'm doing, that it doesn't matter. Well,
that's what they say. Artists can work and work. They have no idea.
I'm in my world. I'm in my hood. I'm in my body containment suit. And I'm just in my world. But the other part of it is that, as 25 years, August 28th. So as you do more and more and more and more, even though you're really not trying to be fast, because you've been there so many times before, you just know how to get there a lot quicker. You can do what used to take 5 hours now in 2 hours, not because you're rushing, just because you've got better teams and everyone knows what to expect, and you know how to plan it, and you know what you do when this happens or that happens. It makes you a much, much, much better primary surgeon when you can do all these revisions.
And let me just tell you, guy here, so many people say, I have to have a knee operation, I have to have a hip operation. Who do you recommend? Well, of course, I only recommend one person, and that's Dr. William Leone. So let me tell you again what his phone number is and how to get in touch with him. It's Dr. William Leone. It's called the Leone Center for Orthopedic Care. It's over there associated with Holy Cross, the Orthopedic Institute. And the phone number is 954-489-4575. And so let me just go into something else. Hips are an interesting thing, but I think it's the knees that really carry someone. I mean, you could have good hips, but if your knees don't work, you're in serious trouble. And I know that now this is your specialty, and knees seem to be so much like a toolbox. I mean, it just seems like, I can think about hips, and maybe I'm wrong, but knees go in and out and in and out and in and out as you walk, so it must be a much more serious operation.
It's not more serious because if it's you, it's all serious, but it does have a more complex movement, and there's almost 2-to-1 knee replacements being done now compared to hips. So there's a lot more people that need their knees replaced than their hips replaced, and that trend is just going to go more and more. So, and the game changer, like I described my very simple, intuitive pelvic alignment level, the game changer with knees has, in my opinion, not just been with the prostheses and the bearings and the plastic and the locking mechanisms, but particularly with the technology to install them. So when we talk about a knee replacement, we talk about either a partial knee replacement or we talk about a total knee replacement. There was a CNS news brief maybe a month ago where ex-President Bush had a partial knee replacement done by a very good guy in Chicago, and it touted on the morning CNN how it's a super operation, it's being underutilized, and it's for the very fit patient because it can give them back a very athletic ability afterwards. And that was true. but it's also a misnomer, because truly it's a partial knee. Rather than resurface the entire femur, and rather than resurface the entire tibia and resurface the underneath surface of the kneecap, imagine now only having one part of the joint, let's say the inner compartment or the outer lateral compartment, or even just the compartment between the kneecap and the femur, as that compartment which is really generating the pain. And imagine now not only replacing that worn out compartment. And although its partial knee replacements have been around really almost as long as total knee replacements, which is more than 30 years, it's still a very, very small percentage of people that have their knee replaced have partials versus total. And the reason is because it hasn't been predictable. There's been a much higher failure rate. But the reason why we keep coming back to that golden well is because the people that do well do exceedingly well. They like it better. They feel more normal. That's a much smaller incision. There's much less dissection. And so everybody wants that. So really the CNN blurb, the little story with President Bush, said that it was really only for the very athletic and fit, where in reality, in my experience, it works beautifully in that patient. But it also works beautifully in the really overweight lady who isn't going to be all that athletic and fit. She just really has a lot of isolated pain, or somebody who really struggles just going up and down stairs because of their patellofemoral joint. So it's more finding the right indications. And then the game changer has been our ability to do it well. So why has there been a higher failure rate? Well, one reason is because doctors are much quicker to capitulate and convert it to a total knee because it's much easier to do. It's so much smaller. But in all honesty, it's probably technically a little more difficult because they're tiny little components, and if you just don't balance them right, they're not going to work well. And so with robotics and with computers and with this Makoplasty technique, it's been a game changer, because working off a CAT scan of the whole leg, the hip, the knee, and the ankle, so you can recreate the alignment. So you have a virtual image of the limb. You synthesize the whole operation virtually before you ever go in the OR. So much of the head work is done way before you get to the OR. And then in the OR, you're fine-tuning the balance. So they're very predictable. Really, I love doing it because people get well so quickly.
All right, and that's very good, because I was going to ask you about the partial knee, because we always hear about that. But it takes an expert like you to know, is it partial or is it full?
Well, the total knee replacement still is without question the gold standard. It's by far still the majority of people that not only get it, but it's appropriate that they get it. And again, if we're going to be honest with ourselves and we start having studies that not just look at how doctors rate the x-ray and how they rate the range of motion, how they rate the stability, and they rate themselves, if we look at studies that ask patients what they think, how satisfied are they after their total knee, believe it or not, 20% of people that have their knee replaced aren't completely satisfied. Now, 95% of hips are. 20% of knees are not completely satisfied. And you have to say, whoa, what's going on here, and why not? And almost invariably, not always, but the vast majority of time, it's because the knees aren't balanced. There's a wonderfully complex soft tissue support sleeve on the inside of your knee, on the outside of the knee, and the back of the knee, even in the front of the knee, that balances the knee. Because when the knee flexes and extends, different than most people think, it's not just an old hinge that extends and flexes. It not only extends and flexes, but it pivots around the inner part of your knee, around the medial compartment. So as it flexes, imagine in your mind how the back part of the femur kind of falls off the back part of the tibia. And then as you extend, it goes back on and twists the other way. So it's called a screw-home mechanism. And the reason why knees then don't feel natural is if you can't recreate that normal kinematic movement. And again, technology, we have technology now tools, if you will, that give me so much more data points to recreate it that the results now are as good as hips. It's fantastic.
And so I have to say that even though Bill had this done, 20 years ago, they're perfect. And so how long do you anticipate, let's say even with knees, and let's say you do a perfect job, and it's a person, it doesn't matter what age, what's going to make it not work anymore? Is it just it's in too long or what?
Well, assuming the components are good quality.
Let's assume everything is good.
Assume it's not an outlier component.
Okay.
It's one of the good ones. If you look historically at the track record of these components, they did well.
Okay.
And assuming it was installed well, it was done by someone who does a lot, and it was well balanced, either the hip or the knee, and there wasn't a mechanical problem, then really, if you look at people that had their hip or knee done 15 or even 20 years ago, and they were well done and they did well, there's about an 85 to 90% chance they're still doing well 15 to 20 years later.
Right.
And so, how do they ultimately fail? If they were really doing well, the plastic, what's the weak link? Everything always fails at its weak link. What is the weak link? What's the part that's really taking the beating? The bearing, the part that rubs together or twists together, it's creating a debris. And that mechanism of the debris particles being created, creating an inflammation and turning on a bone loss. As we're talking about bearings, of course, the world has just gone through this debacle, this whole world, with a re-experimentation, because we did it back when we were trying to figure out what was going to be the best bearing surfaces in the late 60s, early 70s with metal on metal. And that's a different mechanism of failure. That's a really scary mechanism of failure, because more than inflammation, has a lot of systemic. Systemic refers to all of your body, because the metal particles or the high ion levels go all of your body and create a whole host of potential different problems, and some that we just don't know what's going to happen. But locally, it can create necrosis. Necrosis is death. Inflammation is different. So when I reoperate, and I find myself at the forefront of revising many of these total hips now that you're seeing that have been recalled, and they look very different, and that's a different animal, because that creates tissue death, bone and soft tissue death.
Well, I have to take my hat off, though, to orthopedic surgeons, because as a gerontologist, for me, I always wanted people to live a long time, but I wanted them to live with a high quality of life. And of course, years ago, and I wasn't around 100 years ago, but people, if they had problems, they sat in a wheelchair, and that's what they did. But now, your profession has enabled people to live as though they were, 20, 30 years younger. And that's really important. And so I'm proud of you that you're always looking for the next level of the best that's out there. And with robots and with you and your inventions and how you think about things and the balancing, people have to be careful. And I will have to say this, when you're looking for an orthopedic surgeon, I think you have to think that you're going to have this for 20 years, and you better look for the orthopedic surgeon, not how much it's going to cost, but what is it. It's your body. You go on a cruise, you take $5,000, you think nothing of it. Go to the very best orthopedic surgeon, because I know that's how Bill felt about you. He, I no matter where we lived, that's what we would do. And I have to always tell that to people. They cheat themselves, and I think that's really a wrong thing. So Dr. William Leone is someone who he's astute, has a great reputation, and his phone number again is 954-489-4575, the Leone Center for Orthopedic Care. So when you start asking me, who should they go to? They always say, I have a problem, I have a hip. I always say, well, I have someone, and you just really should, they're going to go around and look at different people, and I know they shop, and I hate that when people shop. They shop doctors. I don't even understand that.
I actually think it's good, because
you do.
I think an educated patient is just fine, because ultimately when I take care of someone, they really appreciate it, and they see the difference, and I'm good with that.
Okay.
I like questions, and I'm good with sitting and talking, and I think that's part of it.
Yeah, well, and Dr. Leone is, the other thing is he has a great staff. It's very important that you have somebody that when this happens, he has other people he has to operate on, and he has to have somebody he trusts, and you always have great nurses who are there, answer questions. They take care of everybody very well. So I'm certainly happy that you're back now. You've done you keep doing great things for people, and we look forward to a lot more conversations with you. And I think that when you did the Cure Symposium, I learned so much. I mean, you did a great job with showing every little piece of what goes into my knee or my hip, and hopefully I never have to see you in a hospital. But everybody be careful about falling, because you may have wonderful hips and knees, and if you fall, then that's what's going to happen. So you got to, take whatever you need to do to prevent falling, and we'll talk about that another time. Thanks, Dr. Leone. It was really wonderful having you here.
Always my pleasure.
Yeah.
Thank you.
All right.
You've been listening to The Stars Program with your host, Anita Finley. Join us every Saturday at this same time for another edition of Seniors Taking Active Roles in Society, right here on AM 740 WSBR. The opinions expressed on this sponsored program are strictly those of its hosts, guests, and callers and are not necessarily those of the station, its staff, management, or sponsors.